So they're making this ETL code available, which you license.
Yep. Yep.
So why wouldn't they just convert it and then provide it with
Oh, IBM?
Yeah.
I'm sure that then somebody have to pay them to do that.
Yeah. That way they would ensure that everybody gets the same correct version of the transform data. It just seems to me a very risky strategy. They're doing it free anyway because they're letting you provide the code.
Yeah, so we created the code. We originally thought, oh, well, maybe we'll post this code on the website.
Yeah.
And they were like, no way. Because they said, essentially, somebody can back end our proprietary database out of this. So there's no way you can do it. So then we decided, okay, what's the next different thing we could do? And we came up with this arrangement where we will be allowed to release the code to licensed users that IBM says that, in fact, they're licensed to document it. We basically have paperwork that we have to fill out each time, and then we're allowed to do it. If you wanted, if you are a licensed user, and you want IBM to provide that service to you, I would recommend you write IBM a note and say, I would really like you to provide me this service.
No, but that was a good explanation. Quickly hear the background to that. It just, from their point of view, it just strikes me as a bit more of a. I mean, they've given their approval to that, but it would have been even easier to say that, well, look, the licensees, we can do it, and give it to them.
I would encourage you to send a note to IBM. Tell them that that's what you're the client and you get to say what you want. So.
All right, folks, we're going to get started in about another 30 seconds. All right, folks, welcome back. So in an effort to make sure that we get to lunch on time and leave everybody all of the time that they want to take for their lunch, we're going to go ahead and keep going here. I want to introduce some folks around the room, and actually if there are folks from Harvard Pilgrim Healthcare Institute right now, I'd like you to stand up. So we realize that asking for questions at the break and having them all sort of bottleneck to me is not the greatest idea, because there's a lot of folks in the room who are very knowledgeable about our tools and our data, and they can help you. So I'm asking folks from Harvard Pilgrim to stand up so that you can recognize them and you can go to them and ask any technical or operational questions as well. They're here for us to support our lab for the afternoon sessions and also to talk a little bit more about these case studies. So if you sort of make a mental note of who you can ask questions to, anybody's available, and we're very happy to help you if you have questions. Thanks. So in our part 2, we're going to go through and we're going to do our second step of our feasibility. So recall from our feasibility questions, the first question we were asking is thinking about whether we have enough exposed persons in our population. And we used our medical product utilization, and we saw we had 73,000 users of our typical antipsychotics, and we had 10,000 less, so 64,000 users of our atypical antipsychotics. And now we might want to ask, if we decide that that's enough exposed persons to think about doing an inferential study, how many outcomes do I need to observe so that I can have an adequately powered study if I'm going to proceed on to trying to get to a hazard ratio associated with the risk of stroke following either atypical or typical antipsychotic use? And so we're going to talk about the steps that we need to get to that next step right here. So we're going to go back to this main diagram, and so that we're going to think about where we belong on this diagram. And actually, one of the folks pointed out to me at the break that I didn't say anything about what these types mean. So I'm going to take a minute and say what that means. So essentially, within our Cohort Identification and Descriptive Analysis tool, or CIDA, which is also called the Routine Querying Tool, that is essentially one giant piece of code which has different sort of subsections that ask different types of questions. And depending on what subsection you're in, there are different input files that are required, and there are different parameters that you have to fill out. So the reason that we create this diagram so you can sort of see what kind of question you're doing and where you're going to end up is so that you can pull out from that type, because then if you were to use our public Git site, our dev.sentinelsystem.org, to find the input files that you need in order to ask a question of that type, you can narrow down to exactly what you're looking for. And so I'm sorry I neglected to say that at the beginning of the talk, but that's what the reason of having these types listed here is, so that you can easily map within the CIDA documentation and within the package what you need in order to answer your question of interest. And so now that we're thinking about our outcomes after our medical products, so we're thinking about finding a stroke risk amongst new users of typical or atypical antipsychotics, we're all the way over on the right on our diagram, and we're going to be doing our incidence rates query. And so that's what we're going to be setting up for. This is referred to as a type 2 query, and if you were to go again, user documentation system, type 2 would be what you would be looking for. So now we're going to think about defining our study question. And so this is another sort of organizational scheme to think about our design. And we're going to walk through all of these components. We're going to start out with our study design, where we're going to select our type of analysis, which we just talked about. We're going to do an incidence rates query. We're We're going to identify which cohorts we're going to follow for which particular time periods. Very similar to what we just did, we're going to select our query period. We're going to look at our demographics and our enrollment requirements for our study population. We're going to further use inclusion or exclusion criteria to narrow to our population of interest. Then we're going to define our exposure of interest. We're going to use codes in order to make sure that we have those index exposure events. We're going to talk about whether or not we're going to let people re-enter our cohort once we stop following them. We're going to also talk about, again, the incidence criteria, which you learned about earlier, and the washout period. Then we're going to follow people. We're going to do the same thing we did before with those 3 steps of creating the exposed time, and we're going to see that that time is what we consider their time at risk. We're going to add additional censoring criteria here. So we're going to potentially censor for more reasons. We'll talk about that as we get to it, but we're going to specify what our censoring criteria is, and then we're going to set up our outcomes. So in this case, how we're going to define ischemic stroke and hemorrhagic stroke. Finally, in our analysis step, if I'm doing a descriptive analysis, I'm just going to define which of the baseline covariates of interest I'm going to bring back and how I want to stratify my data. And if I'm going to be doing an inferential component, I'm going to talk about which comparison I'm going to use. What's my treatment group? What's my comparator group of interest? And then what are the tools I'm going to use to actually perform that inference? And so overall, this is the sort of way we're going to go about thinking about this. This and then also our design diagram, which lays everything out more in a timeline. So we use both of these components to sort of make sure we have our head wrapped around all the things that we need to specify. And so this incidence rates design diagram looks very much like what you just saw with the medical product utilization design diagram. So we have, again, still the incident or the index dispensing or administration with an incidence requirement. We're going to look for exposed time. We're going to look amongst a particular study population, which is going to be defined by our demographics and our cohort characteristics. We're going to use inclusion and exclusion criteria to further narrow that population, and we're going to bring back information about that population like you already saw. The new component here that we haven't yet talked about is adding the outcome events. And so now we're going to define an outcome event of interest, and we're going to say whether or not we require that outcome to be the first observed outcome in a certain period of time, our event incidence. And so those are the new components that we'll be dealing with the incidence rates query. As always, we strive to, in addition to having the design diagram, to put down how we specify everything in our study questions into our CIDA parameters document. So we have this document right here. This is a handout for folks who are in our sessions. And so if you have received your materials when you came, you can follow along with the handout that you have right there so you can see what we're doing at any given point in time. This is the document that we use to work with the FDA back and forth to understand how they specifically want to ask their question and how we make sure that we set up the parameters accordingly. So I'm going to continue to reference this specifications document throughout this talk, so it's great that you guys are getting it out and having it handy right now. This is just a sort of zoomed in version of a particular portion of the CIDA parameters, the specifications document. So we're going to start out with our study design, and we're going to talk through selecting our analysis type and our cohorts of interest. We already have discussed that we're in a type 2 query, we're in an incidence rates query. Now what we're going to think about is how many different scenarios do I have to ask? And so the question here is, how many cohorts of interest are there? CIDA requires that we define the study population, the exposure episode, the outcomes, and all the components to it. And if we change any of those components, we actually may be asking a new study question. And so this is sort of a bit unusual for folks who are not used to dealing with a distributed database. When you have access to a full patient-level database and you can see all of that data in front of you, if you want to create a sensitivity, if you want to alter your question very slightly, you don't have to do anything because you have all the patient-level data right there in front of you. For us, because we're doing a distributed query, we have to ask everything in advance. And we have to very specifically say what we're looking for because we only get aggregated data back primarily at the Sentinel Operations Center. So we're not able to on the fly say, oh, well, I want this sensitivity, because what this sensitivity is actually creating a different aggregate cohort. And so we have to be very specific about all of the things that we ask for, so we minimize the transfer of data back to the Operations Center to only what we absolutely need. So in this case, what you want to ask yourself is, what do I want to know about these outcomes after these exposures? And here what we're thinking about is we have two different outcomes of interest, and I want to have the incidence rates for those outcomes segregated. So I want to know the difference, I want to know my stroke incidence rate and my intracranial hemorrhage rate as two different rates. And I want to know them amongst two different populations. In my typical antipsychotics, I want to have that particular incidence rate, and then my atypical antipsychotics. So in this case, I have two different exposures of interest, I have two different outcomes of interest. So in a what's called a full factorial analysis, I end up with 4 cohorts. And so you can think through, if you are going to ask any other sensitivities, you want to, in your mind, lay out how many different rates am I going to get under these circumstances, because that's going to be how many different things I have to specify. And so in your specifications table, which you see in front of you, you see 4 rows. And the reason you have 4 rows is because of the fact that you're going to ask this rate in 4 different sort of ways. And so you also see our little shorthand there for group name. That's the combination of the exposure of interest and the outcome of interest in your particular scenario of interest. So that first one there is typical ischemic stroke. So that's going to be the row of information I use to ask the question, what is the risk, or what is the incidence rate of ischemic stroke following typical antipsychotics use? Contrast that with the second row, which asks the question, what is the rate of intracranial hemorrhage after typical antipsychotics use? So do you see, so on and so forth, how the scenarios are created? So in the end, we end up with a retrospective new user cohort with 4 unique analysis groups in our study design. Now we're going to go through and we're going to select the query period and do our demographics and our enrollment and our inclusion and exclusion. So here, the important point here is that the query period is going to bind your index date. So it's going to be the period of time during which you're going to be able to have a legitimate index date of interest. If you have enrollment criteria or incidence criteria, anything that stretches before that time frame, it's okay, because the query period is designed to be the time period in which you are looking for your index exposure. So here, we're going to use the entire period that we have available in the synthetic public use file. So we're going to go from January 2008 all the way to the end of 2010. And that's going to be the query period we use to bind our index date. We're going to set enrollment characteristics for this particular period of time. As we did before in our feasibility query, we're going to use a 183-day enrollment period. We're going to require medical and drug coverage. Again, we're going to do this because we're looking for evidence not only of dispensings, which would come in the drug coverage, but also evidence of outcomes. In addition, we're also looking for clinical conditions in our covariate period. So all of that's going to require medical coverage in order to be able to ensure that what we're getting back is actually as complete a capture of this patient as we have. We're going to allow for what's known as a 45-day enrollment gap. This is for folks when they have multiple enrollment periods within the same data partner. So what can happen is, if I'm getting my insurance through a particular company, and I have, for example, the Cadillac insurance plan, and I decide the Cadillac insurance plan is too expensive, I need to move to a lower insurance plan, and at the time of usually December timeframe, November timeframe, I have to re-up my insurance, and I change at January 1 for the following year, I end up with a new insurance plan. Administratively, this can look like a gap in insurance because the times might not perfectly line up. We don't think that means that somebody's not covered. It just means that it may appear to us as though they have a period of 30 days or 15 days where they seem like they don't have insurance. If really they didn't have insurance and somebody filed a claim, it would get automatically rejected, and then their administrative database would be corrected to make sure it showed that they had insurance. And so in order to prevent losses from this kind of situation, we have this gap, which is essentially a tolerance for when people change insurance plans within their individual data partner. And so that's the gap parameter we typically use is 45 days. So we're also going to look for a particular cohort of interest. Remember, in the case study here, we're interested in non-elderly individuals that don't have evidence of dementia, and so I'm going to restrict the age information that I bring back to adults ages 18 to 65 on the day of their index dispensing. I'm not going to restrict my cohort to particular sex basically variables, sex characteristics or race characteristics. So for example, if I'm going to ask a question about birth control pills, I might say I only want to bring back information on women because I only expect women to be taking birth control pills. You can do that here to sort of suppress unwanted tables and things like that. Here, we're interested in all sexes and all races, so we don't have to do that, but it's an option available to you. We also have the ability to restrict the population to only individuals for which we could go find a medical chart if it was required for a validation purpose. So within the data set, we have some individuals who have charts that are available to us to validate, and we have others that aren't. And so we can restrict our criteria if we want to only people that have charts if we so chose, because we intended to do a validation study. So here on your specifications document, you can find this information laid out. So in our query period, we have our dates there, we have our coverage requirement, we have our pre-index enrollment, so 183 days relative to index. Everything here is always relative to index, and index is always day 0. The post-index enrollment requirement, meaning any enrollment we're going to require after that index, is 0. We have our enrollment gap as 45 days. We have our age groups that we're interested in creating stratifications for. So what this is going to do, it's going to take the incidence rates that we develop, and it's going to divide those incidence rates into these stratifications. So I'm going to get the rate of ischemic stroke after typical antipsychotic use among an 18 to 39-year-old population, and among a 40 to 54-year-old population, and 55 to 65 separately. So I can see that information uniquely. Additionally, we're going to ask for stratifications by sex and by calendar year of the date of index. So in this case, we only have 3 calendar years covered in the synthetic public use file. We have 2008, 2009, and 2010. So that portion at the top is what we've just covered in demographic and enrollment criteria. For exclusion criteria, these again are clinical concepts that in the more sort of complex or advanced CIDA can be set to particular care settings of interest. So for example, I could say that the clinical concept of interest that I'm interested in here is excluding people with evidence of dementia in the 183 days prior to their index dispensing and on the day of their dispensing, which again here is listed as day 0. I could say that when I'm looking for that evidence, I only want to look in an inpatient setting, or I only want to look in an outpatient setting. Now, usually in exclusions, most people want to actually be, sort of wide, basically allow any setting at all. But there may be a particular time where you want to limit it for particular reasons. For example, say you wanted to exclude people who had a really severe form of a certain condition, and you might say a proxy for severity is that they have an inpatient hospital stay for that condition. The care setting specificity allows you to be very precise in how you want to include or exclude people. So you can see here how this plays out in your specifications table that you have in front of you. There's a section, it's listed as the inclusion and exclusion criteria. It talks about the clinical concept of interest, so dementia is our clinical concept. It says we're doing an exclusion. We're going to look for evidence of dementia in any care setting, so in the inpatient setting, in the outpatient setting, in the emergency department setting. We're going to look for the period of time relative to our index date, 183 days before and on that day of index. And we're only going to require 1 instance of a code in order to exclude. That instance of a code allows you to be more stringent if you would like. You could say, for example, that to really ensure that I'm only excluding people that absolutely have evidence of dementia, I could up that requirement. I could say I need to see 2 codes in that 183 days. I need to see at least 3 codes. So that's a user-specified criteria. We're going to use 1 in this instance, but it's based on how stringent you want to be when you're asking your query. So we've gone through the study population characteristics. So we're looking in the years 2008 to 2010. This is largely because of the fact that we're using the synthetic public use file data. We're looking for individuals aged 18 to 65 on the day of their index date. We're looking for them to have at least 6 months of continuous insurance coverage in that prior period so we can check for our exclusion of interest, which is dementia. And we're going to look for that in the 183 days prior to their antipsychotic initiation, whether typical or atypical. And we're going to also make sure that they don't have evidence of that on the day of their dispensing. So now going to the exposure section. So this is how we're going to actually specify our typical and our atypical antipsychotic users, and how we're going to say whether they're prevalent users or whether we're requiring them to be new users, and then the associated washout period. And so here, back to our design diagram, our index state here is now filled out as the typical antipsychotic dispensing. And so one of the things that I'm going to have to think about when I'm doing this query is how many periods of time do I want to allow this individual have in the data that we bring back to contribute at-risk time. So in the prior medical product utilization query, the way that's designed is it's going to follow people for the lifetime of their information in the data set. And that's sort of the default. Here, we're going to set up for thinking about whether or not we want to allow a person to have multiple exposure episodes of interest. So what does that mean? Are we interested in people who in 2008 who get dispensed their first typical antipsychotic dispensing, and then they only keep that 60-day period where they're considered treated, and then they come off the drug for a year, and then they come back on it? The question is, when they come back on it, do we want to consider them at risk for this outcome anymore? Do we want to follow them during that time period or not? Another way to think about that is cohort re-entry allowed? Do I let people be lost to follow-up and then pick them back up again if they meet all of my cohort entry criteria a second time? A visualization of that is here. And so what we're saying is how many valid index states am I going to allow in my cohort? And we have numbered those definitions with these pictures to indicate in the tool what we're doing. And so in the first definition, we're saying no cohort reentry is allowed. I'm only going to monitor people for their first treated exposure episode, and then I'm going to stop monitoring them. They're lost to follow-up for the duration of my query. In the second cohort definition, anytime they have all the entry criteria met, I'm going to keep monitoring them throughout. And if they have the event again, as long as they've met all my criteria, I'm going to still count their at-risk time. In the third possibility, I'm going to actually say I'm going to keep monitoring them, but once they have my event of interest, once they have an ischemic stroke or an intracranial hemorrhage, I'm not following them anymore after that point. And so you have to make this choice when you're going through and you're assessing your time at risk. And now, in this case, we're thinking about the incidence rates query as a setup for potentially doing a propensity score matched analysis. And in our propensity score matched analysis, because we want to ensure that we don't inadvertently match a person to themselves if they have two different medications, we always use cohort definition 1. We don't allow cohort reentry. And so that's listed here as the cohort definition, the first valid exposure episode with no reentry. Now we're going to think about our new user definition. So here, the exposure incidence always ends at day -1. So whatever our starting date is, the way we specify it, it will always by default end at -1. And in this case, we've already said in our prior feasibility query, we're going to require new use to be the first use in 183 days. So we're going to allow no typical, or in this case, atypical antipsychotic use in the 183 days prior to their index dispensing. And so this information is all captured in this portion of the specifications document that you have in front of you. So the way to think about this is for every row, we're going to first say what is the index exposure of interest we're going to capture. We're going to talk about how many episodes we're going to allow, in this case, no cohort reentry. We're going to say that new use is going to be defined as no prior use in the 183 days. We're going to also say that in addition to having no use of the group that we're interested in, which is the typical antipsychotics, we're actually not going to allow the opposite study drug use either. And that's that column there that says incident with respect to. And it's basically saying beyond the actual incidence defined by my exposure of interest, are there other things I am not going to allow that person to actually use at the same time? And so that's basically a bigger category of things, because it's not only the incident to the exposure itself, but a greater sort of family of things. We always basically put our opposite study drug in this component here when we're setting up to do a comparative study. And so this portion is the exposures part here. So we discussed the new users of the typical versus the atypical antipsychotics, not allowing for cohort reentry in this case, which is called cohort definition 01. And we're going to have it be incidence not only with respect to the study drug cohort of interest, but also the opposite study drug for all of the scenarios in the 6 months prior to the index dispensing. So the next component we're going to look at is how we're going to assign the parameters to follow-up time. And this is going to be very similar to what we talked about in the morning, so I'll go through it a little bit more quickly. First, what I want to say is there's two options for deciding what we're going to call our exposed time, which is another way of saying our time at risk. So traditionally, and what's most utilized is known as an as-treated analysis, which means that while I'm considered actively exposed, I consider myself at risk. And I use that same sort of strategy that I did before, which has got the stockpiling and the gap and the extension. And so here in this diagram, I have two different dispensings which total 60 days, and so my exposed time is 60 days for this patient in what's known as an as-treated analysis. Another option is an intent to treat, which treats the initial index dispensing as more of a point exposure. And basically, at that point in time, I say, I'm not going to actually even assess what their day's supply is or what their treatment looks like in terms of stockpiling and anything else. If they're a new user, I'm going to call them at risk for some set period of time, and that's going to be what I consider my at-risk time. And so in this case, if I set my intent to treat days at 90 days, I'm going to consider that person at risk for those 90 days, and I'm not going to worry about how often they pick up their refills and how to construct a treatment episode. Once they have that initial dispensing, it's 90 days. And so those are two options available to you, as treated versus intent to treat. Most often, as treated is what's utilized. So going back to creating that exposed time, this is exactly what we did this morning, so I'll just review it again quickly. We're going to have the first component be stockpiling. And the stockpiling is a question about whether or not we're going to have these overlapping dispensing periods. And so recall in what we showed earlier, we had a default where we always kept all the overlapping dispensings. When we use the more complicated version of CIDA, you can either throw away all of your overlapping dispensings. And why might you do that? Let me give you an example. So warfarin is an example of a prescription drug that's very inexpensive and is titrated. And as a result of that, people are often prescribed on the same day different strengths of warfarin medications and are given specific instructions by their doctor to take it either together for a certain period of time or to take the lower dose and then add a higher dose. And so what we see in the dispensing record is a lot of overlap. And the question is that overlap actually intended to be pushed out, or are they actually throwing away their extra pills? And so there is an option in CIDA to actually say how you want to treat that overlap for situations like that where you have a titration element. And so we have the ability to range anywhere from throw away all your overlapping dispensings to keep all of your overlapping dispensings, and sort of a spectrum in the middle where you can keep a percentage. You can say, well, if my next dispensing occurs in such a percentage of time of my first, keep it, or otherwise throw it away. And so the stockpiling algorithm is a little more complicated, and if people want to ask me about it, or any of our folks here after the break, we can talk about it, but typically most people just keep all of their overlapping dispensings. The gaps are just as we spoke about before. The gaps are set up as a particular period of time where I'm going to look ahead and see whether or not I have another dispensing, and then allow that gap to be treated as continuous exposure time, and then the extension is just as I had indicated before. And so all these things combined together create your total treatment episode. So in this case, it's 128 days. And again, the order of operations is really important to keep in mind here. And so it always goes in exactly this order. Now, there are times where I might want to say, because of the particular outcome of interest, I may not think that I'm actually at risk for this during my entire exposed time. So there are things, for example, most particularly things like anaphylaxis or allergic reactions, where the idea is if I'm going to suffer an allergic reaction, it's going to be in a very short time period following my initial dispensing of that particular medication. And so if I were to use an entire treatment episode and use all those at-risk days, I might be adding in days where I'm either at lower risk or no risk for that particular outcome of interest because of the sort of clinical presentation of that outcome. So if I'm in a circumstance like that, I can also truncate my at-risk time with a particular parameter, which just says, I'm only going to consider you at risk for up to a certain number of days, and then after that, I'm not going to consider you at risk anymore. And that's a user-specified option. So in this case, what we're showing is I have a treatment time that lasts for 128 days. but I actually think I'm only at risk of developing this outcome in 120 days. So I stopped my counting of my at-risk time at that point. So again, this is user specified. It doesn't have to be used. And it's designed to ensure that you're only allowing, so when you're creating an incidence rate, right, you're creating an outcome over a number of days at risk. You want to ensure that that days at risk is actually representing what you think is truly at risk and isn't potentially adding in a bunch of days that might wash out anything. And so that's the goal here, is to allow that user that flexibility. And so here in our expose time, I use all of those parameters to create this little green box that we're showing for you here. And then here you can find all of this information in this portion of your specifications document, where I say my treatment gap, I say what my episode extension is. If I had a stockpiling that was different from my default, I would indicate that here. Minimum exposure episode duration, so I'm going to allow essentially any amount of an episode. I could say, for example, I only want to monitor people who have at least 30 days of an episode, but in this case I'm going to monitor any amount, so I'm going to leave it at 1. I'm going to allow my minimum day supply, meaning I'm going to monitor anybody who has even a single dispensing for 1 day supply. I'm going to still monitor them here. So that's what that column is. And then I'm not going to use the maximum exposure episode duration. So I'm just going to allow my entire as treated episode to be utilized. Now, if I were to not do an as treated type of an episode, but instead to do an ITT, an intent to treat type episode, I would have a single parameter here that was listed as the ITT days, which is just the set number of days after my exposure that would monitor those folks for being at risk. And so the portion that we just did is the portion of our design that involves the follow-up, how we specified it, what our stockpiling was, what our gap was, what our extension was. So now the next component is our censoring criteria. So which things will actually cause us to truncate our expose time. So required censoring is when we have the first occurrence of disenrollment. So essentially in all of our work, we're striving to monitor the data that we have, and we want to ensure that it's not missing. And so when we're looking for these concepts, we want to see that people have enrollment during the time frame we're monitoring them, so that if they have the absence of an outcome of interest, in this case an absence of stroke, we really think they did not have a stroke, as opposed to it just being missing. And so when they have disenrollment, we censor them because we don't know after that whether or not we can actually say their presence or absence of a particular condition. And so another thing that is a required censoring criteria is when they actually have the outcome. So at that point in time, we think their time at risk is up, and so we censor at that point. There are also several optional places you can censor. One is user-defined codes. So one of the things we often censor on, especially when we're doing a comparative analysis, is when people start the opposite study drug. So say in our example, I'm on a typical antipsychotic, and I'm setting up for a comparison with an atypical antipsychotic. When I start my typical antipsychotic, say I have a dispensing of it, and then I switch from my typical to my atypical. Now if I have a stroke event, I don't know necessarily where I want to attribute it to. And so what I do is I censor them at the switch, and I stop saying that any stroke event that occurs during that time is attributable to their initial typical antipsychotic dispensing. So I use my opposite study drug typically as a censoring criteria, because I don't want people to be on my treatment drug of interest and my comparator drug of interest at the same time. And so that's an example of a user-defined setting that we have. Additionally, you can censor on evidence of death. The evidence of death that we have in the data model we know is incomplete because we don't have access to the National Death Index and aren't able to update every single person for out-of-patient death. However, there are some folks that we do have death information on, and the question obviously is do we want to censor them if we know they're dead? And usually the answer is yes. So we almost always invoke the option to censor at death when we have evidence of death. We also can censor on data partner end date, which is just quite straightforward, and then query end date, so when we're going to stop monitoring the follow-up period. This visual here is showing the episode truncation for the comparator. So essentially you're going to stop that episode as soon as somebody starts that comparator event. And so here in your specifications document, you can see the column that includes all of your censoring criteria. And so we spell that out particularly so everybody can see exactly what's being censored on. And so now that we talked about our censoring criteria, we're going to go ahead and we're going to talk about the outcomes and how we're going to define the outcomes. And so this is, again, a piece that's related, basically new in the incidence rates query, because in the utilization, we didn't really think about outcomes. So there are three important elements to define outcome events. One is how you identify the outcome. So it's any combination of code and care settings. And so this is an example, again, where using the care setting specific scenarios may help you to invoke a measure of severity. So for example, oftentimes people are looking for a hospitalized outcome as opposed to any outcome. And so you use the code and the care setting combination to say where you're going to be looking for this outcome of interest. A second element that is part of defining an outcome is whether or not you're going to use a washout period. So a number of days prior to index when you want to say that the user has no evidence of that event. That will always require enrollment, and it can require no evidence of a related event. So for example, say I wanted to, in my stroke case, I want to define my stroke as only being a hospitalized stroke. So when I look for my event of interest, I'm only looking for hospitalized stroke. But then I want to wash out on any stroke. So if I have any evidence in any other setting, in an emergency department setting, in an ambulatory setting, when I'm looking back to find my evidence of this being a new stroke, I can look back at a different set of care settings than the one that I used to define my outcome of interest. And then the third element that we have here is what we call a blackout or an induction period. It is a number of days after the index date before I really think the person is at risk to have the outcome of interest. And that is when the follow-up period begins. So for example, I can start following somebody on the day after their index dispensing as opposed to the day of. Or I could follow them several days after if I think there's a several days induction period. So that's user specified. Outcomes that occur, though, during that induction period are not counted and do not contribute to your at-risk time. And in fact, because they represent somebody having an outcome, they're pulled out, that episode is excluded. Typically, we almost always have a blackout period or an induction period on the day of exposure. And the reason for that is our actual data itself. So the data that we receive, primarily claims-based data, the smallest unit of analysis is the day. And so because it is the day, I'm not sure if I have the index dispensing and the outcome on the same day, which happened first, because I only know that they happen on that day. And so typically I will use that day, I will not follow people on that day to prevent a reverse causation situation. So I typically will start follow-up on the day after my index dispensing. Now there are some outcomes for which that might be inadequate, like anaphylaxis or something that is expected to happen nearly immediately following an initial dispensing. And so it's a user-specified parameter. It's just something that you have to take into consideration, the limitations of the data that you're using and the inference that you can draw from it based on what's available. And so here I'm showing a design diagram with my event of interest, which is stroke, and then I'm showing my event incidence, which is to say that in this particular query, there was no stroke allowed in the 60 days prior to the event. And so here in this portion of your specifications, you can see how that outcome plays out. So you can see that the event is different in different rows. And again, that's because the incidence rate that you're developing is going to be specific to the scenario you're in. So it's going to alternate between the ischemic stroke definition and the intracranial hemorrhage stroke definition. In all cases, I'm going to be requiring that outcome to only occur in a hospitalized setting. And I'm going to even be further restrictive than that. I'm going to say not only does it have to be in an inpatient setting, but it has to be the principal diagnosis position or the primary discharge diagnosis that that person has associated with them. So that has to be essentially the reason for their hospitalization in order for me to count it. I'm also going to say that I'm going to count this stroke only if it is a new stroke within 60 days, and if I don't have any prior stroke in any care setting in the days prior. And I'm going to wash out, you can see I'm washing out beyond just my ischemic stroke, I'm washing out that other part of the stroke definition. So you can think of my stroke definition as being in two parts, and I'm saying that when I'm looking for a new stroke, I'm looking for it with respect to all strokes, so I want it to be new with respect to any of the prior components. And so here you can see this laid out here as ischemic stroke or intracranial hemorrhage, and it has to be a primary inpatient diagnosis. And then finally, we're going to go to the analysis portion. We're going to start off with the descriptive piece, where we're going to look at covariates of interest and defining them, as well as stratifications. And then we're going to move on to the inferential piece and talk about how to do a propensity score matched analysis. So in the descriptive piece, our covariates are identified by any combination of codes, which can be the form of national drug codes or dispensings, diagnosis codes, or procedure codes. And with covariates, you can specify any combination of care settings, just like we talked about for outcomes, and any number of occurrences. So I can again say, in order for this covariate to be assessed, I have to have evidence of 2 instances of this code versus 1 instance, and it's at least. So basically, you're setting the floor for the number of instances. You also can use complex logic. So you can use and or criteria. So for example, I could say that I want to make sure that when I'm assessing somebody for a particular condition, I want to see a diagnosis and I actually want to see treatment for that condition. That'd be an example of an and criteria. Or you could say I want to be more relaxed about it. I'm going to call them as having that condition if they have either a diagnosis or a treatment. So those are examples of where you can use logic to ensure that you're actually getting exactly what you're looking for. And then the evaluation windows can be specific to each covariate you specify. So in the prior, the query builder query with medical product utilization, we used one window for all the covariates, but it doesn't have to be that way. In the more complex version, you can go covariate by covariate and specify different windows. The evaluation windows are always specified with the idea that the index date is day 0, and they can also be open-ended, meaning that you can look back in what we call ever time backwards or ever time forwards to see if something occurs. And so it can be a preset time period, or it can be any history we have for that particular patient. One thing is true is that one set of covariates is used for all the scenarios. So you want to maximize what you bring back because it's going to be applied to every one of those 4 rows that we have. You're going to get a table 1 or a baseline covariates table based on all those 4 rows. So you want to be as inclusive as you can when you define your covariates. The covariates that contribute to the baseline table, those ones are going to be, again, for all the scenarios. But then scenario by scenario, you can specifically say which covariates you want to bring forward into a propensity score estimation model. So each of those things can then be sort of line by line. You can go through and decide whether or not to use them in propensity score estimation. And so here you see our covariate evaluation window has appeared in the orange box at the top. And we're going to do our covariate evaluation from days -183 to -1. And here in your specifications document, you can see what specifications that were asked for this particular query. So you have a list there. They looked for these covariates in any care setting with any discharge position. So they could be principal, or they could be not. They could be secondary. They could be anything. They had the same evaluation period, -183 to -1, and each time the covariate was assessed, we only required a single instance of that code in order to say that you had the presence of that covariate. And so here, we specified what will become our baseline table of cardiovascular and psychiatric risk factors in the 183 days prior to the antipsychotics initiation. So when we finish out this incidence rates query, which is a level 1 query with a type 2 designation, we're going to produce unadjusted incidence rates, and we're going to produce 4 sets, right, for our 2 different exposures and our 2 different outcomes of interest. When we think about these in sample size calculations, FDA often requests that we get the outcome counts, I'm sorry, it looks like there's a typo there. The outcome counts are pooled by the exposure group. So basically, FDA asks that we don't tell them which treatment or comparator group is associated with the events of interest. They ask us to combine them together in order to do the sample size calculation so that they're not sort of have pre-information about which of the unadjusted rates are going to be higher. The baseline covariates table also provides a sense of the unmatched cohorts before any adjustment is made. It also can give you an early warning on rare covariates that are basically unlikely to actually need adjustment, but may cause havoc in your propensity score estimation model for folks who are familiar with propensity score estimation. So a rare covariate is one that's not necessarily going to create a confounding problem for you, but could cause your propensity score estimation model to not solve properly. And then there are stratifications that are specified that can inform the potential for effect modification. So in this particular query, we asked for age stratifications that came back and sex stratifications as the year of index. And so we can look at those different rates to see if we think effect modification is going on, and then we can use those rates to decide whether or not to ask for subgroups when we do a propensity score estimation analysis or matching analysis. So I'm actually not going to show the results of this query because the way we've set up for today is that we're going to go through all the specification now up front. We're going to go to lunch, and then we're going to pretend like we ran this query in the background, and then you're going to get the results after lunch for folks who stay in session A. For folks who go to session B, you're going to take all of these specifications and you're going to create your own CIDA SAS package, and then you're going to run the query on the synthetic public use file and get your own results. And so that's the reason why I'm not going to show the results here, because I don't want to sort of give away the ending. So in some senses, we're just going to do the design right now, and then we're going to go to lunch and we'll come back for the results. So we're also going to do the specification now for our level 2 query, our propensity score matching analysis. So we're going to take all the information from level 1 and we're going to build on just a few extra components to do the propensity score piece. And so here, we're going to be in the propensity score analysis portion. So we're going to use all of that information, the cohorts that we already developed in that incidence rates query. We're going to apply them to a propensity score analysis where we can use optionally matching or stratification. In this particular instance, in our case study, we're going to use matching. It can be non-sequential or sequential, meaning we could do hypothesis testing going forward in time if we wanted to do a sequential analysis. And the output metrics are going to include the propensity score distributions, the regression outputs, and adjusted hazard ratios. And so the example that we're going to go walk through is, again, the stroke following typical or atypical antipsychotics use in non-elderly patients. So briefly, just going to run through this very briefly because this is not necessarily a methods course, but a propensity score is essentially an index of the probability that we think that somebody will be dispensed the exposure of interest based on a set of information that occurs for them during a pre-specified period of time. And so here, we're going to take all those covariates that we had gathered, so whether or not the person had evidence of any of these things, and we're going to then examine, based on those covariates, what was the likelihood that they would be actually dispensed our treatment group of interest. We're going to do the same thing for our comparator group, and we're going to assign them a propensity score. So you can think of a propensity score as a way to summarize a person's information into a single number, as opposed to keeping all of these separate covariates. We're going to do this in not only our treatment group, but also in our comparator group. And then we're going to choose, in a matching situation, a matching ratio, which can be set up as fixed at 1:1 or variable at 1 to up to n, where n is our ceiling. We're also going to specify what the caliper is when we're going to allow a match, meaning what is the maximum distance between two patients' propensity scores where we're still going to let them match. We always do this on the natural scale of the propensity score. And the type of matching that we used is known as nearest neighbor optimal matching. And so here in this illustration, in my treatment group, I've ordered, at my orange folks, I have their propensity scores listed, ordered from the lowest propensity score to the highest propensity score. And in my other group, I have a similar set of individuals. And you can see that the ones that are matched are the ones that have the tolerance where they fall within that caliper. And I assign those 1:1 matches using the closest distances that are matched first, and then anyone that's unmatched essentially gets dropped from my analysis. So I'm using a 1:1 match. If I don't find an adequate match for a person, I drop them out. The information about my propensity score parameters is in this top portion of my, my specifications that you see in front of me, where it specifies I'm going to be doing the 1:1 match, and I'm going to use a 0.05 caliper. And so when I set this up in my design diagram, I always, the way that we do this is we solve Cox proportional hazards outcome regression model. Now when we do this in a distributed fashion, we actually send our package out to the data partners, and they send back the minimalist data set that we can do to combine only information about the people who have events and their probability of being in one or the other group, which is known as a risk set return. And we run an outcome regression model at the operations center on that data, which is stacked. When you do this in a single database, you would do it all at the same time. You wouldn't have this step of the distribution, the return, and the aggregation. So there's a slight difference here in the way that you would do it when you have a singular data set versus in a distributed network setting. Here I'm adding a little component to my design diagram. That little pink box indicates what I'm going to be doing with my propensity score. I'm going to use one-to-one matching. Then I'm going to use a caliper of 0.05. And then I'm going to, in my estimation model, use age and use sex. And I'm also going to use all of those recorded history parameters that I had as my covariate evaluation. So again, recall that for your covariates, you can have some of them be used in your propensity score estimation model, but you don't have to have all of them. It is completely user specified. So just a really quick note, and this will become more apparent in the Session B lab that we have today, is we've been talking about all of these clinical concepts and saying that we can specify them very particularly, but all of that is done via codes. So when we talk about the concept of dementia, or the concept of ischemic stroke, or the concept of intracranial hemorrhage, I have to name all of the codes that I say are associated with that particular concept. And so in this case, we need to develop the code lists for our typical antipsychotics. So we would do that using national drug codes. Our atypical antipsychotics, also we would use national drug codes. And if you are amongst our international regulators here, who are here for day 3, you would use whatever coding scheme you have in basically your country to do those. National drug codes are the US-based ones, but our friends from Canada use something called DINS. We have other folks that use SNOMED. So there are different coding schema. In this case, because we're doing this case study with our example, we're using national drug codes. Additionally, we have to define what we mean by dementia. We have to say what combination of diagnoses, codes, and or treatments, if we say that a person who's treated, we're going to consider them as having dementia, or procedures. So basically any combination of codes to say what we're going to call somebody who has dementia. We're going to have to say how we define stroke and intracranial hemorrhage, again with a series of diagnosis codes, and we're going to have to say how we define every single one of the covariates we had. So what combination of diagnoses, procedures, and treatments we're going to use for these concepts. And so in all of our specifications document, and the ones that you would see online, you have that main 2 pages, which is what you guys have in your hand, which are sort of keeping everything at a concept level. And then when you see online in our reports, you see additional tabs, and in each of those additional tabs are the definitions for all of the clinical concepts in that table. And so here you're going to see a tab for atypical antipsychotics, you're going to see a tab for typical antipsychotics, and here you're looking at the tab for ischemic stroke. And the way that you read this is that you're looking for these particular codes, which are a diagnosis category of codes. So they could be diagnosis, they could be procedure, they could be dispensing. These are diagnosis codes. They're an ICD-9 code type. So we use typically ICD-9 and 10 code types because in the US, doctors code with respect to 9 and 10 codes. In other countries, if they code with SNOMED codes, for example, then you would have SNOMED as your code type here. So you want some combination of code and code type, and then we include a description so people can read what that means. Frankly, the SAS program itself cares nothing about the description, and it never goes forward. It's used for transparency and for reproducibility. With each of those codes, particularly for ones that are diagnosis or procedure-based, we also have to say again what that care setting is, where that condition is occurring, and these are the possible care settings that we have. We have an inpatient hospital stay. We also consider a non-acute institutional stay. This would be something like a skilled nursing facility. So this is somebody who's in an inpatient environment, but not really a hospital, more like a long-term care facility. There's an emergency department encounter code, there's an ambulatory visit code, and then there's a designation for other ambulatory visits. These are things like home health care. Like if somebody gives a phone call to somebody and does a consult, that actually gets a row in the data model, and it's noted there as an other ambulatory. So it's a contact with a patient, with a provider, but it's not in what you would think of as your traditional ambulatory visit setting. And then you also can just say you want to look for something in any setting. In addition to actually saying what the care setting is, you actually also can say what type of position you want it to be in. Now, in the US, in the inpatient setting, there is the principal, there is the secondary, and then there's unknown. And inpatient diagnoses in our data model carry one of those designations. The emergency department and ambulatory settings don't necessarily have this concept. And so for the most part, it's all unknown in the model. So you use these combinations, and we concatenate these variables together when we specify it for CIDA. So right now, the principal diagnosis I was indicating is only required for those inpatient settings. So our wrap-up of this morning's session, we walked through how we would design, specify, and implement the medical product utilization query using the query builder tool that we showed before, and we showed results from that. We walked through the design and the specifying right now in this second, post-coffee break session, our incidence rates query and how we would set up a propensity score matched analysis. We really focused on how we would be transparent about telling other folks what we were doing using our design diagram and our specifications. And so now this is a part where we're going to split for the afternoon. So for our session A folks, they're going to stay in this room. They are going to review the results of the implemented query on the synthetic public use file data. So they can see exactly what was implemented and then sort of understand what you would get back. And then there's going to be some case studies about other types of queries in the Sentinel distributed database designed to tell you more information about what kind of information you can get back. For folks who are going to go into session B, you're going to take the materials that were developed this morning, those specification documents and those design diagrams, and you're going to sit down with them with your laptop in session B, and you're going to go through and you're going to create all the input files and then run the package against the synthetic public use file data set and create your own results. And we'll walk through then those results. So those are sort of the two tracks. For folks who may or may not want, I should say this, the tracks are not sort of like you're stuck in one of them. So if you decided like when you signed up that you ended up in session A but you want to be in session B or vice versa, it's okay. So it's fine to sort of change it up here. With the session B, it's a laboratory, so it's more useful if you have your laptop and you're able to do it. But if you want to follow along because you're more interested in that and you don't have that stuff, you still could sit in session B. So just as a note, you should choose whichever thing works better for you. And so with that, I'm going to take questions and we're going to adjourn for our lunch period. And again, when we come back, we're going to see the results of the query that we specified. I want to also say that in the session A, you're not only going to see the results from the synthetic public use file data, but you're going to see the actual results FDA got, the ones that are posted on the website and the ones that allowed them to make their regulatory determination based on the case study that we saw today. So both of those things are going to be presented. And yes, and Joy is telling me, at the conclusion of the session, I have to ask you to take out your app again, because we're getting our feedback about how we did during the morning session. And so if you would bring out your phone and indicate to us sort of how you thought we did, any comments you have for us, how our materials worked, et cetera. We'd love to hear your feedback. It would be really great to get that information. There will be a second sort of feedback session at the end of the afternoon. So these feedback questions are only about the morning session. And so we'd love to get your feedback and have you ask any questions that you may have, and we'll break for lunch. So while people are doing their feedback, if they want to come up to the microphone, if they have a question, please feel free.
Thank you very much. One question about the minimum day supply. Mm-hmm. Is that actually from the raw data based on the day of supply?
Sure, yes. So that is from the raw data. So we don't allow in the data model, we don't keep data where it shows a minimum day supply of 0 or negative, which would indicate that people have not picked up their prescriptions. But the minimum day supply is designed to show you, like if you wanted to say, for this prescription, I expect that there should always be at least 3 days supply, no matter what. Like, so if it's an antibiotic or something like that, you can specify what the floor is for when you'll allow it to enter into your query. And that can be done at query designation.
Okay, what if the number is missing or it's like 1,000, which is apparently an error?
So there's also a maximum allowable value for your dispensings that you can set that is query specific. So you can say, if I have any dispensing over 200 days supply, I'm going to throw it away. I'm not considering it valid and I'm not going to allow it to enter into my query. You have that option as well. In this case, in this query, nothing was specified, so any day supply is allowed to enter in, but you have that option available to you.
Okay, so in actual query, there will be more parameters to specify, actually.
So
There's more
some of the
parameters.
ones that we have defaulted or we keep sort of them, there are more. And so when folks sit down for session B today, they'll see some of those, let's think of them as more secondary parameters. They're ones that are available to you, but almost are always specified the same way. We didn't go through all of them today to show you that, but it's an option available to you.
Okay, thank you. Another question. Maybe I missed something, but do you exclude stroke during baseline? Patient who have stroke during baseline?
So that is the outcome washout. So when you look at the outcome washout criteria, it says that there's 60 days.
Yeah.
And so the specification there was if they had the outcome event of interest in the 60 days prior to their index dispensing, so anchored on their index, they were excluded from the cohort. And that's a user-specified option. So if you wanted to keep those individuals, you would just not specify an outcome washout.
Okay. Well, but if they have stroke, like say, like 90 days before index, they are capped in.
So in the way that this is specified, if they had a stroke in 90 days before, they're not washed out at day negative 90. So you'd keep them.
Okay. All right. Thank you.
Hello, Sophie Zhang from HealthCore. Judy, I was wondering, can you elaborate more on how data from individual DPs are aggregated or pulled, like for the propensity score analysis? Do you do any stratified results and then you pull among patients with similar risk or similar estimate of the propensity score?
So in order to minimize the transfer of information back to the Sentinel Operations Center, for the propensity score matched or stratified analysis, we have what's called a risk set return, which is a limited data set that only brings back information on the timing of the event of interest, and at the point of that timing, what was the probability it was contributed by either the treatment or the comparator group population, depending on who was left in your follow-up time at the time of the event. So it's a very limited data set and does not have patient-level information that's returned. We stack that into basically a data set that's used for an outcome regression model. And it's always site stratified because of the nature of us getting it back by the site. If there is a subgroup you are particularly interested in, you have to actually say that at the time of specification. So if you know already that you think that there is effect modification by age, and you want to have a hazard ratio that is brought back for a particular age group, you have to specify that as a subgroup at the time when you actually send out the package, because we don't bring back information unless you specify it that would allow us to get that information later. So everything that you want to think about in terms of subgroups, or basically you can think of them as hazard ratios by a specific value, either an age differentiator or maybe a history of a condition versus not, or a sex-specific criteria. All that has to be specified at the time you send out the query.
That's really interesting. Is there any documentations that pertains to the aggregation of results in the Sentinel website? Because like a lot of the training materials are specific to one database. So
Sure. All of our documentation is available on dev.sentinelsystem.gov. It can always be improved though, so what we should do is we should point you the right direction, have you check out the documentation, and then tell us whether it's adequate to answer your question or not.
Thank you.
Oh. Is there okay.
Hi, that's the first time seeing the GUI interface. I'm assuming that creates the SAS input tables for the query package.
Mm-hmm.
Is this going to be something that Sentinel is pushing for more systematic creation of those input tables, or is there other reasons behind using that?
It's just to make it easier to use. So essentially in the background, if you use the web-based interface, you're just selecting the parameters based on the design diagram, which is more intuitive to many folks than setting up an input file.
I was wondering if also some of the rationale was to make sure people were creating the same input tables. Have you run into any cases where maybe that might not be the case? Any lack of systematic creation?
I guess maybe I'm not understanding what you mean by this, by the different input tables. So normally the way that
well, if you specify a parameter, and when you're creating your own input table, that could have impact.
So the procedures that we go through at the Operations Center when we do this are we have one analyst create what we call the package, where they create all the input files, and we have a second analyst check. Basically, they use that specification document, the same document you have in front of you, and they check independently to make sure that the package matches what was in the specification. And if there's a discrepancy, we find it through our second check process. Now, that doesn't take care of if you actually made a mistake and you thought you were doing something and it didn't do that. So, for example, you could think that you were specifying it in some way, but what you wrote down was not actually what it's doing. And that, of course, can't be checked. You would find that out when you get the results back, and then it's not the way you expect.
I was thinking more for like uniformity across partners that were also creating the packages.
Oh, the way that this works in a distributed network is we send the same package to every partner. They don't create their own package.
Okay.
Hi, can I have a clarification question? Can you go back to the slides where you create the propensity score? No.
This slide, or go back to the
No, go back
specifications?
to the list of the conditions you have for the propensity score.
So back to the covariates, these?
Yeah, well, yes, transient schematic attack. Is that similar to what the outcome is? I mean,
So in this case, these covariates here were utilized to go into the propensity score, and the transient ischemic attack here includes variables beyond the stroke. So it includes heart attacks and other sorts of things that are in this category that are not limited to stroke. And so when they specified this is a larger category of events than just the outcome of interest. And so what that will mean is that the folks with the outcome of interest will get washed out based on that washout period. But this is going to get anybody in the 183 days prior to 1. So it's going to have basically a set of people in there that don't meet that washout criteria.
Hi, Hui Ting Cai from FDA. Thanks for the presentation. Just some question for clarification. So first one, it's right for the outcome we can query it's only limited to the 20A, or for other outcome we can provide the ICD-10 code to still do the query for the outcome here.
So for the outcome in general, you can provide any combination of codes to identify the outcome. So you're not limited to anything in particular. You can, it's completely customizable.
Okay, great. And you mentioned a lot of different type of query for the exposure. They kind of all inform different aspects of the study design. So I assume we can query all together instead of, is there any limit in terms of how many type of query we can do in one time like that?
So when we actually run the package, because the different types have different input files,
Right.
when we run one instance of it, we're only running a singular type. So if your question has many scenarios in it, but they're all of the same type, they could run in one execution of the CIDA package. But say you wanted to run CIDA package with one type and another, that's actually, think of it as running CIDA in a loop. You would run one type 2 file and then one type 5. And so the reason is that the input files are different and sort of depending on what type you're in.
So kind of basically group them by type, but we can ask for multiple type in one time or do different query, I guess.
Sure, the logistics and the administration of it is a little bit specific for the FDA and the way that works, but for anybody who wants to run a package, essentially, they need to run a singular package per type.
Okay, and is there any kind of, do we have access to this web-based interactive?
Yes, FDA does.
We do have, okay, thank you.
So I have two questions. I'll ask the big one. I already introduced myself. You described the problem of this stockpiling plus the gaps. And then you described the concept of a treatment episode. And you actually introduced an interesting third parameter in addition to stockpiling and gap, which is switching to a competitor, which would mean, or switching to a different class, which would also affect and you explained the case where it truncates it. I have actually a general question, not to the type we just selected in this analysis, but the whole concept of the treatment episode. Does it live on the drug ingredient? Does it live on the drug product, let's say switching omeprazole 10 milligram to 20 milligrams? Or does it live on, you define it as grouping, the standard term value set? Does it, or it could be a standard drug class or my defined value set. So if you can describe the treatment episode in more detail, and possibly have you considered pre-computing that, because in many analyses, this might be quite intensive to always compute that again. I simply can have descriptive questions where I pre-compute all treatment episodes for all drugs, for all patients.
Sure.
And have that as analytically ready.
So in the query builder query that you saw with the type 5, it's defaulted to only look at a generic name. So the unit of analysis there is a generic name. So if you had a generic name where you had a 10 milligram version and a 15 milligram version, a 20 milligram version, it would stockpile them all together because they would all have the same generic name. In CIDA proper, you can stockpile by any category that you want. So you can keep the 10 milligrams separated from the 15 milligrams, separated from the 20 milligrams. You can combine them all together. You can use any unit of analysis you want because it's going on the unit of the code itself. And the code is a national drug code typically for this, but it could be whatever kind of code you have. And so depending on the specificity of the code itself, you can treat different codes differently in terms of your stockpiling. In session B today, we'll talk a little bit about that. That's a concept that is a little bit more advanced for what we did today, but it's known as a stock group. And so you can have several stock groups in any particular cohort of interest. But we always do the calculation of the treatment episode at query execution for any proper execution of CIDA. The only time there's anything that's in some ways pre-processed, and even that's not really pre-processed, it just, the unit of analysis for you in the query builder is chosen as the generic type, and it's not a generic name, it's not able to be differentiated. But the treatment episode is always created at execution.
We still have time for my second question. You mentioned recorded history parameters as the covariates, but in your, and this goes back to the very morning session, in your comorbidity, you also have on the top a parameter called prior combined comorbidity score.
Mm-hmm.
So can you talk about how this gets computed and whether this could also be used in addition to recorded history as a propensity score matching parameter?
Sure. So the combined comorbidity score is a particular module that you can include in your query or not, depending on what you prefer. It's its own input file, and so we didn't really talk about it here, but if you want to include it, basically you signal to the program you want to include it by including the input file. It interprets the absence of the input file as you don't want to compute it. And it's computed according to a cited paper about how it's computed, and so we just give the citation for how we compute it, and it measures everything in accordance with how it's supposed to be measured and computed there.
Do I specify the look-back window?
And you specify look-back window. And you can use it in the propensity score, or you can choose not to. It's up to you. All right, and if there's no other questions, or if people have questions on the chat box, maybe somebody can tell me or give me an all clear sign, but otherwise I think we can break for lunch. Okay, so have a great lunch break. We'll see you in the afternoon.
Not